Buenos días, bienvenidos a esta conferencia que se titula El impacto de la transformación digital y la inteligencia artificial en los servicios de laboratorio, a ser dictada por el profesor Damien Gruson. El profesor es el jefe del Departamento de Bioquímica Clínica de la Clínica Universitaria de Saint-Lô en Bruselas. Es miembro de la Unidad de Investigación de Endocrinología, Diabetes y Nutrición de la Universidad Católica de Louvain. También es miembro de la División de Tecnología Emergente de la Federación Internacional de Química Clínica y Medicina del Laboratorio, IFCC, y es miembro del Ejecutivo del Club Tiroideo Belga. Agradecemos al programa de Abbott Visiting Lecturer de la IFCC por el apoyo. Profesor Gruson, le agradecemos su participación en nuestro congreso. Lo dejo en uso de la palabra.
Hello, buenos días a todos para Bruselas. Good morning, everybody. Really happy to be with you today. I will just start the sharing of my screen and hope that's okay for you. Yeah, perfect. I would like to first thank the organizer for the very kind invitation to participate to the 13th Congress, the Clinical Biochemistry. We'll talk about some new technologies and more specifically the impact of the digital transformation and artificial intelligence on laboratory services. I have no conflict of interest for this presentation. I just have some unofficial declaration of interest for today. I am a fan of Paris Saint-Germain, and I'm really exhausted that Edinson Cavani left, because that was the spirit of the PSG. A fan of the KFC Wezenbeek Open, and I just promote the YouTube channel for the music of my son Arthur. So that's my unofficial conflict of interest, and I invite you to listen. Not too bad music. My environment, Brussels, world famous for its main square, the Atomium. Sometimes there is some DJs playing at the top of the Atomium, and you see the beautiful view behind. You know also that Brussels is the capital of Europe, with the European Commission, meaning that there is a lot of political decision impacting healthcare or laboratory medicine for the European Union. And you can imagine that in this crazy time, there is a lot of summit in Brussels to discuss how to fight the societal consequences of the COVID-19 and how to relaunch, if it's still possible, the economy. So that's the surrounding. So there is a lot of group of lobbyists and political decision. There is some strategic plan ongoing around mobile health, also under the lead of the European Commission. As mentioned by Laura, I'm pleased to practice in an academic hospital, Clinique Universitaire Saint-Luc, and we are affiliated to the UC Louvain, the Catholic University of Louvain. We have the platinum label for the ACI accreditation, and you see in the bottom right the new hospital that we should enter in 2025. So that's the environment, and you see that there is some green. Fortunately, there is some green area around the hospital. Okay, and we are surrounded, everyone, by the emerging technology, even on our smartphone, or daily life, And I just take the example of this new French fully autonomous supermarket, Monop, where you have the everything is digital, autonomous, and you could do your shopping within 1 minute to pick up the essential food. So new plan, new autonomy, new technology everywhere, and we are familiar to these emerging technologies. There was on the impulse of the IFCC division on emerging technology, some revision of the new technologies and the transforming ecosystems we are living in. And there is a lot of trends that are already mentioned in a paper that was published last year by the committee. And you know some of them, which could be around the automation, the automated transport of sample by robots or by drones. And there is no live project in Europe, even if it could be in Denmark, Belgium or Italy, the sample transportation via the drone. There is the augmented reality to anticipate the new process in new core laboratories and to see how an automated solution could impact the laboratory process. And there is a lot of evolution around data science and how laboratory data could contribute to several outcomes, which could be operational outcomes, even in the lab, in a production perspective, or in a clinical features to improve clinical outcomes. And there is a lot of evolution because of the rise of the sensors and the mobile device. And you see on your left, on the left side of the slide, that's the European Commission with this motto, next generation union. So a lot of marketing also for the transformation in the European Union. And the same pictures few days ago, something happens in between. In between what? The position paper we wrote with the IFCC committee in our professional and family life. That's this small virus which is impacting us a lot, impacting our laboratory process, impacting our economy, impacting also the transformation of the practice. And it is clear that there was the time before the virus and there is the new normal within and after, taking into account the consequences and the lessons learned from the practices under this pandemic. And yeah, that's the fact. 5 letters, 2 numbers, more than 5 months. We will be almost 1 year after the description of the first cases. Lockdown for almost few months this year. Maybe that could start again. And we see yesterday the announce of professor. He's not yet professor, but President Emmanuel Macron in France for the new night shutdown. Potentially everywhere this virus is turning us crazy and is frightening a lot of people. And it's clearly bring us a change in perspective. change in perspective for what? The need for the triage and the early diagnosis of the people who suspect they could have COVID-19, and the development of digital application for the pre-screening before seeing a doctor to try to match with the probability of having the COVID-19. There is the need to test, and you are facing that. Everyone in the world is facing this motto: test, trace, report. But we need to adapt our capacities. And there is the capacity in the lab, there is the PCR capacity, there is serology capacity, and there is all the new technologies to deploy, and that could help to fight the virus. And sorry, there is some automatic change. The beauty of artificial intelligence impacting the talks. So anyway, and there is the need to avoid the risk of exposure to the infection and to the COVID-19. And that's currently what's happening. People, citizens, are frightened to go to the lab queue for testing, to go to the hospital facility. So there is a wish list to test abroad care structures or distance testing. So a lot of change, a lot of expectation from the people, from the physician. We have also, and it's recognized all over the world, to again back and facing this pandemic. Sorry. To identify this group of people with a higher risk of what? Having severe COVID-19 infection. And this group of risk could be people with, unfortunately, chronic conditions, could be people with some comorbidities, and could be people with lower societal condition, and that's risk factors. And unfortunately, if you are a male like me, overweighted, you have also some higher risk of infection. The risk factors are related partly to the chronic condition already existing in some citizens. And if you look at the number, it's almost 2 billion people over the world, around 22% of the global population, that will have at least one underlying condition, which could be hypertension, which could be diabetes, which could be metabolic disorders. And in those people, around 350 million will have multiple comorbidities and will go for very severe COVID-19 infection, requiring to go to the intensive care unit and to embolize the hospital care facility. So there is a major challenge, is triaging this group at risk to avoid or anticipate the risk of decompensation. And that's a fact. The other fact is the current way our healthcare system are organized. There is a lot of investment, and that's related to the Belgium, but that's most of the case, happening over the world. You are curing, but not preventing. And one of the consequences related to the virus will be to use the technologies and the emerging technologies and the policies to prevent for the rise of chronic disorders and prevent the side effect of an unexpected event like a pandemic. And we know from some European example, if you consider the UK and the Germany, for the first wave of the virus, there were less outcome in Germany because, fortunately for them, they invest more in the prevention and in decentralized care. So if you have some lesson to learn from this pandemic, it's already go for more prevention. Of course, we will not be able to do that alone. It's a more political influence and the political spirits to be put in the healthcare budget. Test, and make the system more resilient, more strong in front of a burden. And unfortunately for us, this virus was crash test for all healthcare systems. It uncovers some frail point in our system, the community resilience, the capacity of mass testing, maybe some lack of synchronization between private and public players, the some cultural habits that were not good, some lack of coordination at the national level. And so there is, beside the prevention, the ability to improve the resilience of the care system all over the world. And at the end of the day is maybe the evolution of the current care framework with more coordination between the different players. And at the end of the day, the pictures could look very dark in this pandemic time, but we should find in these darkest days some hope. And we already have some perspective to keep dreaming. At least the profession, specialist in laboratory medicine or laboratory medicine, has become as visible as ever. So we are now recognized for our value. Everyone knows what is a lab test or a PCR test. So we are visibility. We know also that this pandemic was an accelerator for the morbidity and the death, but it's also accelerator for the technologies. And we learn that the technology could be accelerated because of this fear or this need to face the burden. And I will take the example, maybe emphasized more by the pandemics, but that will benefit to the community, to the management of some chronic disease, and that related to the improvement of laboratory service. And no doubt, the first case is remote monitoring. You are, most of you, maybe already having an intelligent smart balance or having a smart watch or in contact with patient with some glucose sensors. There is a lot of evolution in this Internet of Things or connected tools. And that's helping a lot for the remote monitoring of the citizen. And those data belong, for some of them, to the laboratory data. As a remote monitoring solution, it is clear that there is new opportunities coming also from the field of point of care. No way. If we want to anticipate and prevent, we have some more options for the primary care belonging to reliable and validated and coordinated by the lab point of care technologies. And there is more and more perspective to facilitate the diagnosis of some chronic condition that will be related to high risk in the normal time, cardiovascular complication, renal complication, or severe infectious disease. If you consider the diabetes, if you consider heart failure, there is some remote monitoring possible now in general practice, general practitioner offices or at home. And there's no doubt, and it's in every report of national societies or company, you have the development of the genomics, which is one of the promising or already blockbuster in our field, but there is also the rise of point of care. And we need to be involved in the control of the point of care. And we know, and you are maybe in contact with some point of care system, which will facilitate the PCR testing for the COVID-19, for the flu, or for the serology, but they need to be validated and they need to be controlled by a lab specialist. For the remote monitoring, there is also the rise of the sensors. And the first example was the real-time measurement, the continuous measurement of glucose. And there is a lot of example for diabetes type 1 of the glucose sensor measuring the glucose in the interstitial fluid and the app on the smartphone. And we know that it's clearly improving the life of the patient with diabetes. It's improving the clinical outcome of the diabetes, a better control of the number of hyper or hypoglycemia, a better management of the treatment and the insulin administration. There is a mission for us also. It's to ensure that those sensors are already validated. And if you consider the evolution of the diabetes or the chronic patient, we are facing this digitosome where you have more and more data coming from a digital solution. Even it could be a sensor related to an app, even it could be a data registered to the app. And that's for every measurement solution, you need to get a control on that. It's comfortable because compatible for the remote monitoring, the continuous monitoring of chronic disease, but we need to have a bit of involvement in these sensors, ensuring that there is regular control of the sensor. You can imagine that's the case in some country, that the glycemia is controlled regularly at the lab in parallel to the sensor to have some checkpoint. And the same for the INR, the same for some other condition. And the sensors are not only for diabetes. There is development already available for other conditions like heart failure. And you have a sensor that allows to monitor the concentration of natriuretic peptide, potassium, or some marker related to the kidney function. So there is a mission for the lab specialist to be counseling at the beginning of the development of the sensor to ensure that it's fitting for the practices and for the regular control with the predicate device, which could be at the lab. But no doubt, these sensors are becoming part of our life as citizen or patient, but our life as lab specialists, and how to control and ensure the reliability. So remote monitoring is the first point, and the first big trend that will be accelerated post of this COVID-19 crisis, and where we need to offer services in the control. Another lesson learned from the COVID-19 pandemic was the rise of telemedicine. As the patient were not able to come to the facilities, they were in contact with the doctors with some application. And according to the different countries over the world, there were a rise of telemedicine. Maybe the speed of implementation was different according to some legislation and regulation, but it was a solution for the contact between the caregivers and the patient. That's illustrated by this slide. The rise of the telemedicine and the rise of the telemedicine was at least used in oncology department, teleoncology, department of some urology, the teleurology, cardiac disorders, and you have the satisfaction for the caregivers, and there is a willingness from the citizen, because the patient, sorry for the jump between the slide, there is an issue, but I hope that not too problematic for you. So there is a willingness of the patient to keep being monitoring if they have a chronic condition, or to be able to have access to a caregiver, even if there is pandemic. And the telemedicine for us could also be represented as tele-laboratory medicine services. So we could provide with the new solution some advice, counseling to the patient for the pre-analytics, or before coming to the labs, or before using sensors, or to the doctors to how to use the test or how to interpret some more complex laboratory results. We could organize some video conferencing for multidisciplinary consultation when it's needed for oncology, and you have the team of the oncologists, the lab, the anatomopathologist that could be all around the table, but virtually, and could help to guide for the next steps for the care of the patient. We could educate and monitor the competencies of some staff at the hospital using point of care, and we could support the interpretation of the lab in a remote way by tele-laboratory medicine. And I'm convinced that something which will develop faster and faster. So the remote monitoring was my first point, and the services that the lab could provide there, the teleconsultation, and there is also a third observation, which is related to artificial intelligence. Artificial intelligence is already in our daily life, at home, Google Assistant, Amazon Assistant, in your device, in the remote car, autonomous car, or everywhere. And at the end of the day, back to the lab, there is more and more sources for data, which could be the laboratory informatics system itself, and we have millions of data in our LIS, or billion if you put it at the global scale. We are going to the health data space in many countries, and you could share the data between the electronic medical records to the health data space. There is the omics, and there is new players like the digital app, even if for diabetes or heart failure, that could provide data. So there is data all over us, and we should take a good part of this big data. Yeah, the example coming from YouTube, where previously they were manually reviewing and curated the video that were fitting for the YouTube policy or not. Now they are improving the creation of the video published on YouTube through an artificial intelligence tool. So there is example already available outside the field of healthcare. Inside of the field of healthcare, there is the data that we're having in ON, but there is also the willingness, and I'm back to the European example. The citizens are willing to be digitalized and to share or access to their own health data. So the change in the perspective also happening there, because they want that the doctors in Belgium could connect to some data that have been observed in the vacation time in France, or between different specialties. So there is a willingness of the citizen to share and access to the data. There is, of course, the worries from the citizens who are more related to the question around the privacy. So I want to access to my data and I want to share my data, but I want to be sure that we are respecting the principle of privacy of all data protection regulation if we are considering the GDPR rules in Europe. AI was used in the pandemic, back to the example of the pandemic, to the monitoring of the disease, the number of cases, so the public health surveillance of the progression of the COVID-19 pandemic, the identification of clusters, and some application to conceal the patient to where to test or not. That's some sweets from Belgium that I would like to share with you. So you know that we are very famous for fries, for waffles, for chocolate. That's the good news. However, we are more exposed to cardiovascular disorders. And this observation is valuable for all over the world. So the rise of cardiovascular disorders, cardiometabolic disorders is rising. We have some okay, the mic is off now, better. We are not cross-matching. So the rise of cardiovascular disorders and the benefits for artificial intelligence have been already listed in another publication from the IFCC Committee on Emerging Technologies. AI could, by the integration of data, provide more powerful engines for the early risk estimation of a cardiovascular disease, could integrate data, could be related to the ECG, the troponin, and some parameters like the gender and the age to improve the diagnosis of myocardial infarction, for example, and enhance the monitoring by a better integration of some patient specificity or individual variability. So the power of AI is already illustrated and using the lab data with a lot of examples in the field of cardiology. I would like to emphasize that with two more concrete examples. First one is the atrial fibrillation, and you know that atrial fibrillation, unfortunately, is something more and more prevalent. We could diagnose it by the ECG, but we could also facilitate the diagnosis and the prognosis by biomarkers. And there is evidence coming from the application of AI and data science to some proteomic search to identify biomarkers. And the example here published by Chua and colleagues was the identification through machine learning of two biomarkers, BNP that you all know, and the FGF23, which is the fibroblast growth factor 23, which is an hormone involved in the regulation of the bone and mineral metabolism, a phosphaturic hormone, but also having some adverse consequences for cardiovascular remodeling. So identification of biomarkers related to atrial fibrillation and the integration in an engine with age, sex, and biomarkers to improve the diagnosis and estimate a risk of adverse cardiac event on mid and long term. Still in the field of atrial fibrillation, there is some transcriptomic analysis of genes that are up or down regulated under atrial fibrillation, and that's coming from transcriptomic analysis of right atrial biopsies, and you compare the big bunch of data in the cases and the data coming from controls. You identify the gene, you have a big picture like that, really easy to read, and once you have this bunch of data, you could apply the algorithm from the machine learning and identify some clusters, highlighting some physiopathological change in AF. To interest, you identify interrelated biomarkers, and by identifying a pathway, you could maybe identify a treatment. Even it could be pharmacologic or immunotherapy. The second example where application really of AI really fits in, heart failure. And data, very recent data for the improvement of the diagnosis of heart failure. You know maybe that there is different kind of heart failure. The heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, where the patient could be less symptomatic and where the natriuretic peptide value could be lower, and the moderate cases. And the diagnosis is very challenging, especially for the preserved and moderated forms. And there is application to the artificial intelligence treatment of the data to develop, and that's the orange bars in these figures, artificial intelligence-based clinical decision support, just support. So facilitate the decision from the lab specialist or from the cardiologist. And you see the efficiency of the screening. It's clearly more efficient for all three forms of heart failure. So by combining the data from the lab and from the echography and adding that to the human know-how, you could improve the diagnosis. More interestingly, and you know that for patients living with chronic disease, there is not only quantitative data, but there is qualitative data. It's really important to understand from the caregivers or the helpers or the patient itself, what are the factors that could affect its quality of life, its quality of care, but it's qualitative data. Now, with the science of qualitative data, you could integrate these data, and you see the Picker's principle for the patient-centered care. They could be integrated and retranscribe to algorithm that will integrate all the components or all the opinion of the companion of a multidisciplinary teamwork, which is the case for chronic disease, like the caregivers, the patient, the helpers, to better advise for treatment and to better assist patients with maybe more complex disease. Another example of the application. So we are now outside of the field of cardiology, back to the coronavirus. And you know that there is thousands of publications now around the COVID and the biological signature of the COVID. You could use the search engine from AI to integrate this data, identify some pathway, and at the end of the day, develop some companion algorithm or sensors or biochip that will help for the diagnosis or management of the COVID-19. The avatars, the avatars are the in silico data. So before application to the practices, so modeling by the data, what could happen. Very helpful and very used currently to the development of drugs in the field of cardiology. And you see if the drugs could correctly fit into the receptors and activate or inhibit the signal. You could use that for development of vaccine, and it's already in use for the COVID-19. And it's also avatars to model the process in the lab. So how could I be more sustainable by treating the data from my lab and applying in some space some automation or some automated algorithm for better test prescription or test utilization. So avatars and more clearly modeling of the data before implementing a new process or before testing a new drug on clinical volunteers could be relevant. So there is clearly the value of artificial intelligence for supporting value-based care, ability to integrate complex data from omics, monitor the use of resource, so what we call resources stewardship and demand management, and real-time monitoring of some chronic condition and the risk. And if you use the hypothesis of 1% efficiency of AI tool and considering the cost of cardiovascular disease at the European scale, you could have economy of 2 billion euros with the application of AI to some of the basic principles of cardiovascular medicine. So that's the dream. That's the ability to go for some evolution of laboratory process or services, but it's not so easy. There is a lot of challenges in front of us. The regulatory transformation to make this technology fitting the legal framework, the ethical challenges, the guarantee of the privacy of the data exchange for the patient. There is a need to educate the healthcare workforces and to train them to this new technology. There is a need for the interoperability of the data. If you want to share the data at the health data space system, you need to ensure that there is structures, data that could be exchanged. You need to ensure some communication between public and private sectors also at a time. There is also the need to define the economic value of the new services and what could be the business model or the reimbursement model for these new technologies. So there is a long list of challenges that we have to integrate to make it more suitable to our practices and facilitate the transfer to the routine. And we are transforming also our practices. So our skills and competencies will evolve with more competencies for the digital and mobile health solution. We are also new players with data. We are master in data for some central labs, middleware, but we have not the opportunity to integrate more data. And at the end of the day, it's not only the new lab services solution or emerging solution. We need to ensure altogether the definition of a new financing model and regulatory framework. We need to ensure that the infrastructure is already in place to support the transition with new technologies, and the 5G that's coming more pragmatically speaking live by next year could assist in this remote monitoring, transfer of data. So the infrastructure is really key for that. It's also a question of training and profiling the workforce of the future. And I'm really proud of the work done by IFCC, national societies, and the Committee on Emerging Technology to try to train and present the perspective related to emerging technology. And congratulations to the colleagues and to you, because you are part of this transition. And at the end of the day, it's not only the emerging technology, it's also building care pathway. So how you can early on go for some prevention using some lab data and make it more flexible between the primary care settings, the hospital care settings, and having more support in the primary care to decrease the length of stay in the hospital, which is the global trend. And at the end of the day, not only emerging technologies, but it's building that all together with lab specialists, doctors, nurses, general practitioners, IVD manufacturers, to be sure that we are fitting for the needs. So design the technology and the laboratory services according to the need of the doctors or of the patient. And yeah, some of my last words, and to finish on time, it's not only emerging technology, but it's also new players. That's the solution that Amazon will distribute for the monitoring of some disease. So there is new players in the field of testing, Amazon, some direct-to-consumer providers, and we need to ensure what will be the impact on our own practices and how we could have some control on the services that they will propose. And unfortunately or fortunately, we are in a society of consumerization. So the patient is not only a patient, he's a citizen with some consumerization wishes and looking for top quality lab services. And to conclude, the technology will not change the future. That's us, with the help of the technology, that could change the future of patient care, improve patient care, improve prevention, and improve some clinical outcome. And be sure that you are active players to this process, and your daily job is really important by validating the transition of these new technologies and lab services. So once again, I really would like to thank the organizer for the fantastic opportunity to be with you today in Uruguay, even by the dream. But I feel this Uruguayan spirit. Really appreciate that. I would like to wish you the best for the Congress, and congratulations for the organizer. That's a really top organization. Thank you very much.
Muchas gracias, Gruson. por esta conferencia tan interesante, nos deja bastante en qué pensar. Lamentablemente no tenemos tiempo para las preguntas de la audiencia. Agradecemos nuevamente al programa de la IFCC de Abbott Visiting Lecturer y a la audiencia les pedimos que luego completen la encuesta que le va a llegar por mail sobre la disertación del profesor que acabamos de escuchar. Muchas gracias por su atención.
Gracias.